Welcome everyone to today's webinar, How Intelligent Automation Transformed UCHealth's Auth Process. I am Brian Zimmerman with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We are looking forward to hearing your questions. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. And at this time, it is now my pleasure to introduce Heather Kawamoto, the Vice President of Product for Waystar, who will introduce our presenters. Heather, take it away.
Great, thanks so much. Hello, everyone, and thank you for joining today's webinar. We certainly hope you find today's session both informative and insightful. And it's my pleasure to introduce our two speakers today. Carrie Valtierra has been in healthcare for 18 years, 10 of which has been at UCHealth in patient access. Carrie is currently the Senior Director of Operations for Patient Line, Ambulatory Referral and Authorization. She holds a bachelor's degree in business administration and a master's degree in healthcare administration from Regis University. Brent Reitkopf is also joining us as a speaker today. Brent is the Director of Pre-Access, overseeing insurance verification services and authorizations for hospital billing. He has also held positions in financial counseling, insurance follow-up, and insurance billing. And Brent has received his master's degree in public health from the University of Northern Colorado in 2009 and has worked at UCHealth for the last 15 years. And with that, I will turn it over to our presenters, Carrie and Brent.
Thank you, Heather. First and foremost, Brent and I are extremely excited to be here today to share with you our journey that we have been on for, gosh darn near 3 years now. We are hopeful that what you get from this is just some tips and tricks, some lessons learned. As you journey through this process for your organization, it's definitely been a huge win for us. And we're, again, very excited to share this with you. I just want to quickly go through kind of what we're going to tackle today. We want to give you some background on UCHealth and the organization that Brent and I work for. Kind of make sure you all understand where we were prior to launching some automation processes for referral and auth. And of course, how we designed it, how we implemented it, and really the nitty-gritty of FTE optimization and real-time results around ROI and on our rev cycle side. And again, we will spend some more time specifically on those lessons learned. Brent and I have several lessons learned from on a personal side, an operational side, but really just hoping that what you get from that you don't make a mistake that we made as you journey through this. So I'll kick it off here with our UCHealth background. We are a 12-hospital system across the state of Colorado with 3 affiliate hospitals in 2 additional states, in Wyoming and in Nebraska. We are academic and medical group. We have presence of both. Our academic is the CU School of Medicine that is in our Metro Denver region, and then of course our medical group side across the rest of the system. We have about 24,000 employees across the system, and just also for some clarity, this is our fiscal year 19 fact sheet. I was hoping to get fiscal year 20, but of course that just closed for the end of FY20 just closed for us. So this is FY19. We again have between all of our systems, so just for also clarity, we have 12 hospitals now, but as you'll see, there's only 11 hospitals listed. We had our 12th hospital that opened up in August of last year, so it didn't quite make this list, but we do have 12 hospitals now. Between all of these hospitals listed, it's about 136,000 inpatient admission and observation visits. And we have about 3.8, almost 3.9 million outpatient visits across our system. So we definitely just wanted to give some clarity here and give some context so you kind of know what we're working with here from our system standpoint. We are 100% an Epic shop. I know that's always a question that comes up, but we are Epic based here. So let's dig into our prior state reality and kind of the life that we lived, that Brent and I lived prior to doing this automation journey. So Brent, I'll let you speak to your pre-access side and kind of where you were, and then I'll speak to, of course, the referral outpatient on patient line.
Yeah, definitely. Thanks, Carrie. Yeah, so like Carrie said, so I'm over pre-access. We ensure the financial clearance for all of our bedded patients, so inpatient and observation, and then anything hospital-based surgeries, both outpatient and inpatient, and then some higher dollar outpatient procedures. We kind of work in tandem with Carrie on some of those, and some my team handles as well. So we mostly hospital-based across our system. And essentially where we were at is, we were manually following up on all of our authorizations, relying on the portals to log in and check that status. And if there wasn't any portal or we couldn't find that, we had to make the dreaded phone call and spend some time on hold and just call that payer and manually follow up that way. To be honest with you guys, when we first started looking at these products or some type of automation, my FTE bandwidth was pretty much maxed out and even a little bit over for just what our current system volume. And we knew that we were having some growth coming up. We were adding a couple facilities, always adding outpatient areas, et cetera, and we really couldn't, we didn't have any scaling for this, and that was a big concern. It was, just keep adding FTEs or try to find some other way to handle it. Because we were doing manual follow-up on everything, this, was very inefficient. We had to, you can make 10 calls and maybe the first 9, it was just a quick, yes, this is authorized and you can move it on, but that 10th one required some type of intervention, and if you can get rid of all those easy ones, you could get to that 10th one that much quicker. And so we were in an inefficient process and really looking to make it more efficient and direct what is needed to our users at the right time.
Yeah, thanks, Brent. And on the patient line side, so the ambulatory referral and authorization side, it's a very similar story. And many of you are likely looking at this slide going, yep, this is our life right now. This is kind of what we're dealing with because this is the reality of referral and authorization. And this is the vast majority of individuals who live in this world are doing it manually and are muddling through that and trying to figure out how to be better at that. And for the outpatient referral and authorization side, my team was responsible for approximately 75% of all outpatient clinic visits, in-clinic procedures, all the GI procedures that took place, and of course our radiology exams that were happening across the system. The same story as Brent. Everything was manual. Everything was a phone call. Everything was a fax. Everything was done via the payer websites, and as much as we all would love to get rid of faxes and get rid of the payers who make us send these faxes, that's just not going to happen. So we really had to figure out what we were going to do with all of those scenarios. For my team specifically, every single FTE that I had, every single body that I had, they would spend 60 to 70% of their day solely following up on pending requests that they had already submitted, which meant that it reduced the time that we had to submit any new accounts. They were just trying to close out the ones they started, and we could not get that far ahead, and we could not really focus on getting things out the door. So that was definitely something that was going on across the board. And the same thing, inefficient touches. So we would touch multiple accounts multiple times a day, just trying to secure the auth or to make sure that we knew what was going to happen for that patient before the patient came in for their visit. Oftentimes that meant that we wouldn't know what is going on with that patient until the day before a visit or 2 days before a visit. And that's obviously not a good patient experience. That's not good financially for our organization. And I can tell you one of the biggest things that would come up often with that specific issue and that specific reality is we would have GI patients that were checking in, or better yet, would find out the day before their GI procedure that it's not authorized and that patient's already started the prep for that procedure. And that is the worst possible outcome for that. And we obviously wanted to try to fix that. We knew it was a problem, and that really kind of led us down here. But this is where Brent and I were up until last year when we went live. But our journey really started about 3 years ago, which I'll definitely spend some time on that timeline. But this is where we were, and I'll show you where we went. So next up, we'll talk about designing and implementing future state. So the design and implementation of future state. So what Brent and I did is we really sat down and figured out, what do we need this product to have? At the end of the day, what are our top priorities? What do we want to make sure is there, both from an operational standpoint, from a usability standpoint, from a maintenance standpoint? We went through and figured out what has to be there in order for us to even consider that product. And really what we came down to at a high level was we had to reduce the number of touches per account. We knew on both sides of for both of our teams, we knew that that was a problem. So we had to somehow reduce the number of touches. We had to decrease that manual work that was happening within any step of our process. It didn't matter what step that was, we needed to see if the product we chose could decrease that manual function of that. It had to remain in the EHR. Again, that was epic for us. So we were already logging into payer portals, and every person had 15 different user IDs for all these different portals, and we were already doing that. So if we could find a product that stayed within Epic and our users could simply stay in the world that they know and go from there, then that's what we wanted to have. It had to be a low system and operational maintenance. So we didn't want to bring in a product that would require our IT team to constantly be managing. We didn't want to bring in a product that would require Brent and I, as operational leads, to constantly be troubleshooting and constantly be managing on that side. That's not the goal, and that wasn't the idea when you start talking about automation. When you talk about automation, you really want a tool that truly can be automated without somebody having to intervene, either during the process or after the process. And then the last thing, of course, was we needed a reliable product team involvement and resolution-oriented. So we needed to ensure that the product that we went with was truly in it to win it with us, that truly felt like that we were their partners, and if we fail, they fail type of mentality. And we wanted to make sure that if there happened to be some sort of downtime on the product, that somebody was there to really help us. Like Brent and I were new to this. We didn't know what we didn't know, and we needed to make sure that somebody was there to help us through that. And then the other piece with that is really updates. You all are very aware of how often insurance policies change, and referral and authorization guidelines and rules change, and CPT codes, what may have been authorized yesterday is no longer authorized today. So we had to make sure that the product that we chose would have quick turnaround times when there were those types of updates. So those were our product must-have criteria. And then from there, we really turned that into, if we could find a product that had these must-haves, what would we realistically expect to see on the back end? So if we could find that, here's what we truly felt that we would see both on a patient experience side and then a financial side. So we 100% expected that if we could find these products, then we could increase the automation that would return better data and real-time data back into Epic. And ultimately, at the end of the day, when things are said and done, we felt that we could see an automation rate of approximately 60% of our accounts that would be automated, or have some sort of automated authorization result. The other piece is that we felt pretty confident that we could reduce denials related to no auth by 30%. So all these denials that come through with the specific remit codes from our payers that were solely related to no auth, we felt that we could reduce that by 30%. And then last but certainly not least is truly that patient experience and increasing our service levels. Like I mentioned before, it was not uncommon for us to be trying to figure out what's going on with this patient the day before a visit. That was not an uncommon scenario on either of our teams. And so we wanted to be able to increase that service level and knew that we could if we could find this product in order to focus both on getting accounts out the door much quicker, but also being able to follow up on pinned accounts automatically and it not require somebody to manually log into the portal and check the accounts. So this was really how we arrived at our expected results, and all of that stemmed from what did we absolutely have to have and what was important to us and what was important to UCHealth. So let's talk a little bit about timeline. So I won't spend too much time on this, but I do want to just hone in on a couple of points here. So as I mentioned, we are approaching just about 3 years of our journey on this, and that starts from when we were first trying to identify a product and identify a vendor, and we started that in September of 2017. By January of 2018, we had identified that product that we felt that we absolutely could partner with, and the product that we felt had checked all the boxes from our product must-haves category, if you will. And that was really how we came to partner with Waystar. And that UCHealth Waystar kickoff took place in October of 2018. And really those first couple of months, so October to December of 2018 is where we spent most of our time just making sure we all were on the same page as to what UCHealth needed and then where Waystar would come in for that, where we shared our product must-haves again, of course, and started talking about workflow. Between November 2018 and January 2019 is really where we had to spend a lot of time with our IT partners and Waystar to authenticate all of our users and make sure we weren't going to have any security issues and run into any concerns there. We spent a couple of months on referral types in Epic for us and understanding what that meant both on the UCHealth side and on the Waystar side. I won't get too detailed there, but really what had happened is we set up Epic on our side with referral types that didn't make sense or didn't match what the service was for. What I mean by that is, for instance, we would have an MRI that was, instead of the referral type saying MRI, it would just say prior authorization. And what does that mean? That, like, nobody knew what that meant, and there's certainly no way we could have automated if we didn't fix that. So we spent time fixing that, and then really designed the workflow and what it would mean for our end users and how it would look to them and how it would work from an IT standpoint, and then moved into the bot build. So the bot, really, and I'll get into this, but the bots are the automated function of this. So instead of a human having to navigate the patient portal, or my apologies, the payer portal, the bot is what's built to do that for you. And so every payer had to have a bot built. So we spent time doing that, and of course that led into our testing, which is a good solid couple of months between April and May 2019. And then our training. So once we had all of that done, we of course had to train these end users and make sure that they all understood how this would look and what it would mean on their side when they got certain responses back from these automated statusing, or the automatic statuses. And then we went live June 4th of 2019. We made the decision, so we've been live a little over a year. We made the decision at that time to really rip the Band-Aid off and go live with as many bots that we had built at that time. We didn't do it by payer. We didn't do it by service line. We didn't do it by order type. Brent and I kind of decided at that time that if we're going to do this, we're just going to do it. And this is new to a lot of us, and we're just going to get in there and go live and figure out where we need to where we might need to fix some gaps And that's what we did. And thankfully, the partnership that we have with Waystar, they were supportive of that and were willing to partner with us after that decision was made to kind of go back and fix any issues that we saw. So this was really our 2-year journey in just a couple of bullet points. Okay, so let's talk a little bit about, at a high level, what this really looks like. So from start to finish, and just for some context and obviously some clarity here, Auth Initiate and Auth Status are part of Waystar's automation suite solution, so that is what they call their modules. So just for some context there. We did go live with both at the same time. So essentially what happens is when an order is placed in our EHR, again, we have Epic, so when it's placed in Epic and the service is scheduled, I do want to specifically point out that it is based off of scheduled services. That is how this product functions. But for us, that was already how we were functioning. So in our centralized referral authorization world, we only work scheduled services. We don't spend time trying to auth things that may or may not get used. And we made that decision about 4 years ago. So this worked for us. And just so all are aware, it is based off scheduled services. So what will happen is the order gets placed in Epic, and from there a 278 message is generated. So a notification is generated on that account. And ultimately what happens is it goes out and it pulls the procedure code that is attached to that order, and it will bounce it off the pre-cert list for these payers. So if it's an Anthem and it's for a colonoscopy, then it's going to pull that code for that colonoscopy. It's going to go bounce off of Anthem's pre-cert list, and right away it's going to tell you if it's authorized or not. If that order is in fact authorized, we never see it. It never comes back to any of our work queues to do anything with. So that first layer is the 278 message that goes out. It's either authed or it's not authed, and we go from there. If it requires an authorization, it's going to come back into our work queue. Again, if you recall, our product must-have is that it needs to stay in Epic. So that's going to come back into Epic, into our work queues, and from there, we actually, a staff, an employee in the team will initiate that, will kick off that auth initiation. So when they kick off the auth initiation function, it will launch into the payer website. So it's going to launch into the payer website, and it's the bot that actually navigates the payer website. It is not the person that started it. The person just simply kicks it off out of the work queue, and then it goes from there. So it will navigate the payer site. It's going to fill in all the information that a human would fill in on that payer website, and it's going to submit the auth. At the end of that, it's either going to authorize right then and there, it's going to pend, or it's going to deny upon completion of auth initiate. At that point, really anything that pended is going to follow the auth status process of Waystar's product. So the auth statusing, we personally at UCHealth chose to have it status twice a day. So we have it go out at 5 a.m. and 2 p.m. I think. So really any account that's pending and waiting for a status to be returned back, it'll auto status it for us. So if you recall, 60 to 70% of my staff were going out manually to follow up on these accounts. Now the vast majority of these are auto statused, and they actually can spend that time submitting new accounts. So twice a day that's going to go out, or you can manually inquire at any time that you want to. And that's all done. The status updates are of course found by the bots that are out there. The bots will go back out and check those, and they'll return into Epic via 278. This last part was a UCHealth workflow decision for us. We made the decision that if there's no payer response 3 to 5 days prior to the date of service, then the account gets escalated to an end user. So if there's no status, or if there's something going on with that account 3 to 5 days before, we manually pick it up so we can troubleshoot what's going on. Okay, I'm going to turn it over to Brent, and Brent's going to talk a little bit about our FTE optimizations and what we were able to do by freeing up some of our staff's time.
Yeah, thank you, Carrie. Yeah, so I'll just kind of chat about some of the results that we've seen post-go live and kind of talk about that and some of the takeaways for you guys. And the first thing is FTE optimization. Like Carrie said, we wanted to increase that bandwidth so we can handle that growth. Prior to the project, we anticipated that that FTE bandwidth would increase about 35 to 50% per FTE per day. And really what we saw is, yes, our bandwidth increased, and we were able to, on average, be from 2 to 3 days out in securing that authorization on the surgical side, and we moved out to 7 to 10 days out from that data service and securing that authorization. So definitely saw some increase there with that increased bandwidth, just ability to handle a little bit more volume. We knew that with that FTE savings that we projected, we estimated that prior to the project to being about 13 to 15 FTEs between both of our teams. And what we wanted to do with that savings is be able to reallocate that to handle growth, focus in other areas, etc. And what we estimated utilizing, our salary information, that savings alone was about $624,000 to $720,000 per year, just in that total FTEs that we would not have to request due to growth. Again, kind of tying into that reallocation, Carrie was able to expand her service line, and they onboarded 11 primary clinics and 67 specialty clinics, and again, without adding any new FTEs in the fiscal year, taking that on and covering that. Like we mentioned, we were adding new facilities. We onboarded 2 new facilities and a surgery center late last year. It was between June and July of last year. When I looked at that just for the services that I covered, I anticipated if we didn't have any of this product, we would need 4 FTEs to support that growth. And we were able to bring those on and continue to support those new facilities without adding any FTEs. Just with that and just with the new facilities that we had added and just normal growth in our current facilities on the inpatient side, I was able to reallocate an FTE from my surgical team and move that to my inpatient so they can do the inpatient notifications and insurance verification. So essentially a net neutral FTE add there. So, we realized a lot of our optimization around FTEs through implementing this product. All right, now into some of the other numbers that we have with this. The first piece that I'm going to talk about is just the volume of messages that get sent out between Auth Initiate and Auth Status. I want to focus first on this green shaded column in the table below here. And these are all the authorized status or no auth required statuses that come back from the bot. And what we categorize these as is basically not needing any staff intervention, right? Because it completes everything and essentially completes it out of our work queue once it pulls back these statuses. And you can see that the first number here that, when we started, we were around about 30% of the total volume. that is sent out on these statuses, and we've peaked at about 47% in January, and hover around there. Things are a little bit different these days, just with the changing atmosphere and what we're all going through right now. But so this only goes up through February. But what we are able to do is essentially look at all of the messages that we're sending out, and we realize that it's just the number of 280 or 278s that are going out. It doesn't equate directly to an account, because sometimes it can take multiple messages to go out on an account before you get a status back, a workable status back, whether it needs to be staff intervention or it comes back as authorized. And that's usually about 2 to 4 messages is what we're finding. But we did a lot of deep dive into those messages and how we had that build. We realized that we were sending out messages that didn't need to be sent on accounts, and we cleaned that up, and we cleaned up the statuses that we were getting back and really understanding what does that status mean to make sure that we have a usable status. And so we were actually able to decrease the total volume of the messages going out, but make them more efficient, so it increased that authorization value coming back as well. And then with that, we had some calculations just based off of, Carrie and I talked and said, if we just had a staff person going out and checking these, how much would we expect them to work per day, and what would that, so we can equate it to an FTE, so to speak. And, again, through all that work that we've done, we've been able to kind of quantify that, on average, we're saving about 9 FTEs per month just in what's coming back as authorized. The next part that I'll kind of talk about on this page is the yellow highlighted section here, the staff intervention. And these are those statuses that, it's either denied or they need something. It basically requires staff to do something. And we're hovering right around about 20% there. And we really think that, between what's coming back authorized and what the staff has to touch, it's kind of the sweet spot that we found in working with these, and kind of where we want to keep these numbers and try to get them up a little bit higher on that authorized piece. But I think we're kind of where we should be with these numbers. And then that orange shaded part is just the kind of in limbo pieces. These are the ones where it's just going out and it doesn't have that status yet, and it continues to check. So it's just kind of in a holding pattern until it either goes to staff intervention or to authorized. So then the next piece that I have is just some of the percent automation that we've seen in Epic. And this is a fairly new dashboard component that we just got added within the last couple weeks here. So the numbers only go back to the beginning of the year. And essentially what this does is this takes anything that we've done with our real-time authorization products, so the Waystar products, and what Epic classifies as auto status assignment, and that's just where you essentially say, all right, we know for these payers, this procedure never requires an auth, so it never hits our work queue, it just auto-authorizes. And then it looks at the total volume of everything that has been approved throughout our system. So it's not everything that is controlled by Carrie and me, but it's our entire system. So it kind of takes all those numbers and then comes up with this percent. And what we've found is, so the beginning of January, beginning of this year, we were around about 38% automated. And then last month in June, we increased that to 44% automated. And when I took this snapshot on the 12th of July, we are actually at 60% automation rate for all of our authorizations between RTA and the auto status assignment. So definitely increasing that, and it's a multifaceted approach to work this problem, but have seen some good numbers so far with that. Then we looked at what were our denials, pre and post implementation, and when we started the implementation process, we decided that we wanted to really look at the volume of denials that we were seeing related to no authorization. Instead of using the dollars, we just felt that sometimes dollars can be skewed by one high dollar account or not, so the volume we felt would give us a better representation of what we were actually seeing if we were making improvements. And what we saw is that really the monthly average from the fiscal year 19 to the beginning of fiscal year 20, that monthly average, we saw a 46% decrease in the total volume of denials related to authorizations, coming back on that. And then, of course, as you decrease that volume, you're going to see some decrease in write-offs, and we saw that as well. When we started this project, we were at about 0.5% no authorization write-off compared to all of our write-offs as an organization, and we decreased that by 0.4% down to 0.1% post-implementation. And I think this went through February again, just looking at kind of pre-COVID numbers here. So definitely saw some good denials results with this product. And again, it's a multifaceted approach. This definitely played a big part in this. We also had just as an organization, we focused on denials in general and had some other projects related around overall denials that also helped us identify and decrease these numbers. So with that, we're going to kind of move into our last slide here is just some of the lessons learned. And again, from Carrie and I talking, we've given this presentation a little bit before a couple different times, and just in general, we like to do some post-implementation surveys and kind of get together as a group and just kind of talk about what went well, what didn't, and this is just some of those lessons that we learned here. The biggest one is this is not magic. It's not a super pill or anything like that. We still have to have controls in place, before, during, and after to monitor the effectiveness and reliability of this product. We did want, something that was low maintenance, but just given the states and just kind of the nature of authorizations and dealing with payers, you do have to have a group that is on top of this. It's definitely not a set it and forget it type of thing. You have to, maintain it and just make sure that the whole group is engaged, and we continue to be engaged throughout this process. We felt that you need to engage front-end users and identify those super users very, very early on. Just in general, when you're starting this project and you're looking kind of high level, us as leaders, we can do that, but we're not in the weeds of all of the policies and the procedures. And you really need those super users to help you call out where those road bumps might happen, and help you solve problems before they exist. The other thing is just whatever vendor, however you choose to tackle this, you need to make sure that you're speaking the same lingo. When we first started, and just on like the referral types and what actually was covered, there was some confusion. We had to go back and talk and regroup with Waystar and say, all right, are we talking about the same thing? Because we would call one thing, and they might call it something else. And we found that we were actually talking about the same piece, but just saying it a little bit different. So just ensure you're on the same page there with your vendor and you have everything covered. As Carrie spoke to in the beginning here, cleaning up the referral types is important, depending on how your EHR handles this. But again, when we started and implemented Epic way back, the way we did it made sense, but it didn't make sense to do it that way if we wanted any automation, right? So we definitely had to clean that up. So make sure that is right before you get started. Obviously, and I say obviously, but it wasn't obvious to us, we needed to include our IT partners, right from the get-go, right from the starting gate. We brought them in a little bit late, I think, and realized that, before we picked our vendors, they had a lot of good questions, and we had to do some rework in choosing the vendor because we didn't bring them in early enough. So make sure they're engaged. I think one of the things of why we are successful and why this was a successful project is we do have a very engaged team, and we continue to meet with the vendor, with Waystar, pretty regularly. There's a weekly IT team meeting to go over and just make sure build is good and things that we're working on to optimize and all of that, and everything is going well there. We then have a weekly meeting with operational leadership. Again, just what are the users seeing? Are there any issues or issues being resolved? Waystar is very engaged in both of those calls. And then Carrie and I meet with our customer rep bi-weekly just to go over things that we don't need the whole group for. And again, just, checking in really quick. So it's very, it's an engaged and a team-oriented process, and I think it needs to be, and it's always going to be that way. Meetings might be 10, 15 minutes or, very quick check-ins, but essentially we weren't able to get to that point if we didn't have these regular ongoing meetings when we first went live, and keep them up. And then the last thing that I'll say here is just make sure that you have a good grasp on what you currently are collecting as far as data and reporting on, and then how do you want that to look after you implement some type of automation, and do you have everything that is needed to keep track of those numbers, right? We looked at a lot of things based off of that Auth status and classified what was pulled back from Auth status and Auth initiate, created new statuses for those so we can report off of those. So we had to make that change and create something new so we can go out and say, yes, these are pulling back, this number of statuses. So just kind of have a good idea, and I think that's always an ongoing type of thing, and sometimes when you get into it, you don't know what you want to track until you look at it, and you're like, well, what about this? So just try to think of all of those what-ifs before you go. That's what I have for lessons learned. I don't know, Carrie, did you want to add anything to this slide before we open it up for questions?
No, I think you hit it all. I guess the only thing I would add is from the on the engaging your front-end users, we went through the whole fear process. We had staff that were really afraid that they were going to lose their jobs if we automated some of this, and we had to take some time and make sure we calmed those fears, because we had never had an intention of losing FTEs by any means or letting anybody go. We know the volume that we have and that we will continue to have either by growth or organic growth, that those people were still going to have jobs. But that came up more than a couple of times, and so just make sure that you are having those conversations right up front, because we learned the hard way that, we never thought that they would think they're losing their jobs, but that's what they did think. So make sure you address that early on. And having the controls in place is, you have to have the controls in place on the back end. If anything, to make sure your staff are still using this. We have found along the way that staff would stop using it because they thought it was broke. And it wasn't broke, it just, there was something wrong with the bot. And so we had to have it rebuilt, and making sure that we circle back and are having those conversations and having those real-time check-ins to make sure that everything is going as it should. But yeah, other than that.
Cool. All right, I think we're ready for questions.
Excellent. Thank you so much, Carrie and Brent, for sharing all those details about UCHealth's journey with us today. And we will now begin today's question and answer session. Please submit any questions you have by typing them into the Q&A box you see on your dashboard, and we will try to get through as many as we can. We've already had a ton of great questions come in. The first one we'll start with here is this attendee asked, did you do much process redesign standardization prior to designing automation, or were your existing processes already largely automation ready?
I can take part of that, Brent. So I would say in general, we were automation ready for the most part from a centralized standpoint. So we had the foundation, we had the teams, we had the workflows in place. Again, I think where our biggest lesson learned from where we were not ready is around that referral type conversation. When we went live with Epic, again, we just tried to get bare bones up and going and try to get there. And unfortunately, with that, one of the decisions that had been made was we would just build all these referrals with the referral type of prior authorization. And that doesn't mean anything to really anybody, or it means something different to different people. So we had to rework that and get that going. But I would say overall, and Brent, definitely you can speak for your side, but I would say overall from an outpatient standpoint, we were there. We were ready for the automation because we had the foundational structure there.
Yeah, I mean, we definitely wanted to keep things as close to how we were doing them, you know, as far as the process-wise. What we had to change and understand, again, is those statuses that come back, and we did a lot of work around that as well, and created a nice spreadsheet, you know, not only to direct the bot build and when to put things in the batch, but also for our users to reference as far as saying, all right, when it says, you know, partially certified, it really means this, and this is what I should be doing on that. So we made it fit our current workflows.
Well, thank you both so much for sharing your perspectives on that one. And the next audience question we'll take is the attendee asks, did UCHealth need to do any work with optimizing order sets to be certain CPT codes transmitted for prior auth were complete and accurate?
Yes, a lot. If our IT partners were on this call, they would just laugh. Yeah, so we did. We had found that when we went through this, there were orders that were, the order name was just there, but there were no linked chargeables to it. There was nothing really assigned to it from a standpoint of like what really needed to be associated with that order. There were several that had the CPT codes on there, but as we really dug into this, we found that a big chunk of them did not. And so we did have to work on that and had to get those orders set up to where the CPTs were there on all the orders, or and the chargeables, of course, were there too. So yes, we did have to look into that prior to.
Yeah, and from a surgery side, this is just an ongoing struggle, really, is even just getting the CPT codes sometimes for my area. And so we continue to do a lot of work to make sure that happens upon the order, but if it's not, my team is the one that's following up with that provider as to what that CPT is. So definitely a lot of work on both ends for that.
Thank you both. And the next question we'll roll right into. So the attendee asks, how do you handle late add-on, which would be scheduled 3 days or less? Are these handled by staff given the few lead days to secure an authorization?
Yeah, so kind of both. So anything under 3 days, essentially, if it gets on there, we still run it through the initial 278 notification process. It's instant. It's going to tell you right away if it's authorized or not. If it does not authorize and it comes back into the work queue indicating that an authorization is likely required, then staff will pick it up manually, especially if it's same day, next day. because at that point we're going to call the payer. So we won't waste our time even submitting it on the portal ourselves. We would have never done that. We would have just called for same day, next day. So we kind of have different criteria that's in there, and it kind of depends on what it's for or what payer it is. But overall, I would say it's still a combination of both. We do the notification, the 278, and then there's a portion of them we'll pick up and call, and there's a portion of them we'll let them status out.
Yep, that's it. Carrie covered everything from my standpoint as well.
Excellent. And so for this next question here, it's sort of a few questions wrapped into one. So I'm gonna read through it and open it up to you both. So the attendee asks, how does the bot answer the specific clinical questions needed for some authorizations? Does it draw from the information on the EHR, or does it have other domain sources programmed in? How does the system handle health plan medical policy requirements for new procedures?
Yeah, so yep, go ahead.
Yeah, no, you go ahead. You can answer the first part.
I'll take the clinical side. You can take the other side. So the clinical question side. So that's actually a really great question. We at this time, I know there's other things in the works with Waystar, and I know that they are working on this clinical necessity piece. But at this time, somebody does have to manually answer those questions. So the questions are not. The bot's not going to plug those questions. It's not going to answer yes or no. Somebody does have to manually get there. So where we run into that the most is on the radiology side. We're going to see it mainly on the radiology order side, at least from my teams, and they are answering those questions manually. I don't know, Brent, do you want to take the policy one, or I can?
Yeah, I need a little bit of help on that one too, but I think I'm remembering the question or understanding it. But essentially, if it looks at, like, if it's experimental type of thing, like a new procedure type, you know, it's not going to catch that as far as if an auth is required or not, if the payer doesn't have that in there specifically in their policy. So it would come back as no auth needed. But on, like, the radiology side, for example, you know, there are some things that we have built into our process that would direct things to another work queue for a nurse to review, just to see, does it meet, you know, is it really investigational, or does it meet medical necessity? And that's only for certain CPTs, I believe. That it looks at. So it's not everything, but you do have to be careful, and that's kind of where our overall, all of our processes kind of work together to identify those. So we have a denials review process as well, and we can identify if that becomes a trend on some, you know, procedure and update it to flag those for our users. For that, so that is definitely a limitation.
Yeah, I would just add to that. We have a pretty unique setup and what we've kind of implemented for UCHealth. I'm just speaking solely to the radiology side, which Brent touched on, is the clinical review function for our nurse review, if you will. So for a lot of our radiology orders, so mainly the high end imaging, so your PET scans, your MRIs, et cetera, your high dollar, if you will. What we do is we have a layer of a nurse review in there. So at the point that a order goes to a pending status of any kind, the nurses pick it up and make sure that we've submitted everything clinical that we can to them for them to return a decision quickly. Or if we haven't, they answer any questions that we can provide, with the whole goal of it being stop it before it goes peer-to-peer. Because once it goes to that peer-to-peer status, our teams can't do anything, and the ordering provider has to step in. And we all know that that's our ordering provider's favorite thing to do in this world, is peer-to-peers. So we truly try to stop it going there, and that's the goal of that function. So they review the policy for the patient, as well as the imaging guidelines for conservative treatments and things like that.
Excellent. Thank you both so much for tackling that and unpacking all that information. Some helpful clarity there. We've had a bunch of great audience questions. I really appreciate all this engagement. We have time for maybe one or two more. So I'll throw this one out there next. The attendee asked, do all payers provide the 278 responses, or is this only for some limited payers? If limited, how many payers?
Yeah, not all payers do, so it doesn't work for every single payer. We were able to utilize our major payers, so I think we have about 8 payers that we are using. And essentially, if it goes to a portal, the bot can go out and check it. And really, the 278 isn't going to the payer, so to speak. The 278 goes from Epic to Waystar, excuse me. And then they take that information, and then the bot goes and says, all right, this is for United. I'm going to go to United's portal. I'm going to pull all this patient information, look that up, and then feed that back into, in our case, Epic via that 278. But, if it's like a rental network or, PHS or some of those other funky ones, and there's not a portal that can go through and it can actually pull that information, it's not going to be able to do anything for you. Those are the ones that you have to continue to manually work.
Great. So the next question here, kind of a follow-up. So how did the authorizations get back into Epic, i.e. system interface?
Yeah, so like I said, it's all done through the 278 messages. It sends that back into Epic, and then, I'm not IT, so they go and they pull that information, from that 278 message and are able to kind of send that information to the right spots in Epic and complete it. So since it's all done via the 278, there's no like screen scraping or anything like that can get funky if things change. It's all just loops and segments within that, and ones and zeros and all that type of stuff.
Great. And with just a couple minutes left here, this will be our last attendee question. So the attendee asked, you mentioned that the solution had to accommodate the ever-changing payer prior auth requirements. How does your solution handle this? I think you've touched on this before, but maybe just a final round here.
Yeah, I can take that one. So Waystar does a great job of proactively scouring these patient portals, these payer portals and their pre-cert lists. So any time that there's an update that is, or an updated list, it gets put into their system so that we're constantly using the correct list. So they proactively monitor that and do that and do what they can to make sure that we're using all the right information. In the event that we find on our side that something maybe came back authorized and should not have, or something came back that it required authorization and actually does not require authorization, then we simply provide that information over to Waystar with a screenshot of what we're seeing, and then they help us investigate that. And if the end result is, in fact, that we need to update that logic and update that criteria, then they update that on their side.
Thank you so much for tackling that one. And before we sign off here, Carrie, Brent, any final thoughts for our attendees today?
I think my final thought for you all, if you go, sorry, Brent,
no,
if you're going to go on this journey, and is really spend some time thinking about what you need for your operational department, but also what your organization needs. Like, really spend some time determining what you truly need, or maybe it might be a wish list in addition to what you need. But spend some time on that and really make sure you're focusing on the end result being what you want, so you have the right expectations going into this as you start looking for vendors.
Yeah, you took the words out of my mouth, Carrie, so yeah, that's exactly what I was going to say. Yep. find what works for you
Yeah.
and roll with it.
Great, some great thoughts to end on there. And so that will conclude today's webinar. I want to thank Carrie and Brent again for their excellent presentation and Waystar, of course, for sponsoring today's webinar. Enjoy the rest of your day, and we look forward to having you join us for future webinars.
Thank you, everybody.